Good evening, everyone. We'd like to call the meeting of the full Board of the Community Mental Health. First item is adoption of the agenda. With motion and support, any discussion on the agenda? All in favor signify by saying aye. Aye. And then before we continue, I just wanted to say Brian Agovin will not be here tonight due to the death of an extended family member. So he asked for an excused absence. Next is hearing of the public. Is there anyone from the public that would like to address this body? You have 5 minutes. Please state your name and address, and we'd like to hear from you.
Hi, my name is Buddy Smith. I'm a residential provider in Macomb County and Oakland County. I wanted to, well, do you want my address too? Is that what you said?
Please.
52853 Tacoma Narrows Drive, and that's in Macomb.
Thank you.
Okay. I wanted to talk to you about the urgencies that we're experiencing, and we have been experiencing probably for at least 2 years, and it just keeps going from bad to worse. Two major issues are Office of Recipient Rights and training. Office of Recipient Rights, it's getting outrageous, the demands that they're putting on us, and it's not realistic. Even the training, I've been questioning my staff after they go through the initial training, which is face-to-face. They walk out of there feeling defeated before they even start their job. They're told that they have no rights. They're told that pretty much they're not going to last. It's just ridiculous. And for people to go into training and be knocked down before they even start their job, right then and there is a huge negative, and it's impossible to get staff. I have one home that's been short-staffed for 2 years. I cannot find staff. I'm one of the higher paid providers, and I'm paying $10 an hour, and it's not doing anything. We can't find good staff. There's a waiting list of folks trying to get into these vacancies that we have. In that one home that I've got 2 vacancies that I can't fill because I don't have the staff to fill them. So, and then on top of it, we've got demands for training, and the newest one, and I'm not saying training's great. Office of Recipient Rights is great. We need to protect our folks and their rights. I understand that. But when you're so nitpicky and when we're trying to resolve it, and we have to send out this memo, and then they have to approve it, and then we have to get it to all of our homes and all of our folks and get it back to them in an unrealistic time frame, that's just not realistic. So these are problems that we're facing. I know you probably can't do anything about it. I just feel that you as the board should be aware of what we're all up against. And I've been around for 30 years, and I have never seen it this bad. And it's just going from bad to worse. And I know John knows, and I know Jim knows the issues that we all have, but I just wanted you guys to realize and know too that our folks, actually I've had a number of family members and guardians after a PCP will talk, and they'll come right out and say, is my family member going to end up back in an institution because of all this? Is just crazy. And I honestly tell them, I don't know. I really don't know. It's scary. I've never seen it continually this bad and going down this bad. And every time we think it's the worst it can get, something else happens. And I'm very worried that I don't know where it's going to end up. And the training, the newest one is this nonviolent crisis intervention. Again, I think it's a great training idea, but it's mandatory that even our clerical staff attend this 7-hour training course, that on top of us working all of our staff like crazy, I mean, my overtime is outrageous. Now I have to impose on them yet more training on top of already the enormous amount of training that we're required to have and continuing to have every year or every 3 years. You know, it just never stops. And we're doing our very best to try to get everything done that we're required to do. But when I got this one, I just said, how are we supposed to do this? Everyone is supposed to go to this additional 7-hour training class with no additional funds, And I'm going to lose about $100,000 corporate-wide this year. Basically, and I report this to my board, that when is enough enough? I refuse, I've worked too hard to just throw it all away when everything is finally just depleted. When I feel like there's a lot more out there that we can do, but my passion and my heart has always been in this mental health field, and I love what I do. I want to carry this on with my daughter works for me, and I would love to see her take over the business and keep it going. I would love to see that, but I don't know where we're going to end up. That's all I have to say. Thank you.
Thank you for bringing that to our attention, and somebody from the staff will get back with you. Is there anyone else that would like to address this body? Anyone else? Seeing none, we will go on to item number 4, which is to approve the minutes of the regular meeting of the board that was held on May 23 of 2018. Motion by Flynn. Support by Selena. Any discussion on the minutes? All in favor signify by saying aye. Aye. Opposed? Motion carries. Next is approval of the standing committee meeting minutes of the personnel meeting held on June 4 of 2018. Motion by Doherty, supported by Bush. Any discussion? All in favor signify by saying aye. Aye. Opposed? Motion carries. Next is the minutes of the Program and Budget Committee that was held on June 13 of 2018. Motion by Doherty, support by Flynn. Any discussion on those minutes? All in favor signify by saying aye. Aye. Opposed? Motion carries. Next is item number 6. There's a number of them. Items A through H we've already covered at our previous Program and Budget Committee.
Move to approve.
Move to approve items 6A through H.
Yes.
Okay. Support. And support by Bush. Any discussion or questions on that? Lou?
I'd like to separate C and D.
Separation of C and D. All right. Anyone else? All right, so right now we're going to vote on 6A, B, E, F, G, and H. All in favor signify by saying aye.
Aye.
Opposed? Motion carries. And we're back to items C and D. Do you want to take those together?
Together is fine.
Okay.
Move to approve.
Support. Motion by Flynn, supported by Doherty. Any discussion? All in favor?
Aye.
You want, all right. Opposed?
I'm opposed, record me as the no on both.
Yes, okay. Motion carries. Next is item I, a request to approve the CMH committee assignments for the months of June 2018 through May of 2019. That's a one-year assignment.
Move.
And that was sent to you separately.
Yes. Move to approve.
Motion by Flynn, support by Kraft. Any discussion? All in favor signify by saying aye.
Aye.
Opposed? Motion carries. Consider yourself assigned, everybody. Next is item J, approval of the fiscal year 2019 contract between Michigan Department of Health and Human Services and Macomb County Community Mental Health for Medicaid managed specialty supports and services concurrent 1915 BC waiver programs, the Healthy Michigan program, the Flint 1115 waiver, and substance use disorder community programs. Could we have a motion? Motion by Doherty,
Support.
support by Flynn. And John, would you like to address that, please?
Sure. Nice to see everybody tonight. This is your Medicaid contract. Comes to us a couple months earlier than it has historically done so. And if you turn to page 100 of your packet, I believe, you'll see a memorandum from Kimberly Cope to myself that summarizes some of the activities that have been related to the 2017-18, well, not the 2017, the 18 and the 19 contract. What was brought before this board once before was amendment number 1. So you have the 2018 contract, and it takes on amendment form. Kimberly negotiates those contracts on our behalf in her counsel. And so she's brought along, and the board has already approved the First Amendment. But as you read through it, you can see the changes to the contract itself. And then later on last year, we brought along the Second Amendment to the board. So as you look through that, you can see additional changes to the PHP contract, and they're brought together in whole for the 2019 contract. And I'm being told by Kimberly that there will be additional amendments that will come out for the 2019 contract. But what you've seen mature and develop over 18 and now 19 is the Medicaid contract. It's, you know, it's worth probably $180-70 million. We don't have the rates yet. That discussion will occur a little bit later on tonight, but it's my recommendation that the board approve the Medicaid contract minus the rates, and we have to turn that around in a couple days. So my recommendation, if you have any questions, I'll take those for the PHP Medicaid contract.
All in favor signify by saying aye.
Aye.
Opposed? Motion carries. Next is item K, request to approve contract with professional consulting services to provide services to prisoners exiting incarceration.
Move to approve.
Motion by Glenn, support by Bush. Just give her an overview on that.
Sure. As a follow-up, I also sent you an email on Friday kind of giving you a synopsis of what this contract was about. Years ago, there was Michigan Prisoner Reentry Initiative, MPRI, and it was how do we help those consumers who are those folks that are being paroled and offenders who are coming out of state prisons, on how do we connect them with services right away, mental health services and substance abuse prevention services. If they're in the state facility or in the prison for a long period of time and you discharge them or parole them back to their neighborhood, they're going to reoffend right away. Many of them are not on Medicaid. That's improving. That's been improving over the course of time with Michigan Department of Corrections. But many of them are not on Medicaid. And so there's a gap between the time that they're released, they're paroled, and when the services are readily available. So the Michigan Department of Corrections has had this initiative going on quite a while. The name of itself, as far as prisoner reentry, has changed. I think it's simply called prisoner reentry right now. The MDOC subcontracts with professional consulting services, PCS, who then turns around and works collaboratively with us in effort to make sure that those few folks who do come out of state prisons, who are ours, not Medicaid, we know they need mental health, substance abuse services. We link them right away. We make sure there's no gap in services. We coordinate their care and meet their need upon discharge. The irony of this contract, and I think maybe I'll throw that at the state of Michigan, I don't have an answer for it. It's almost 2 years old, and I'm asking you to approve it now in September. You know, it's already gone through a 2-year maturation point. It is what it is. We're being reimbursed for the services that we did provide. There is a fee schedule that's attached to your agenda there on the amount of monies that they're reimbursing us for the services that we already provided. And, probably is, my position would be, let's not wait 2 years for the next contract. I reach out to PCS, and there's PCS representatives here, the three ladies over there, right there. There are some of the PCS representatives. They want to see this contract go as well through. But I think the message back to PCS and then the Michigan Department of Corrections is give me a contract that we can affect the 1st of October and let the board approve it as well too. So therefore, I certainly recommend that you approve the PCS contract for all the well and good that it provides to our inmates on release on parole. And I'll take any questions.
Linda.
I'm familiar with another program through CARE that they're implementing with people
If it's not in there, then I would have to defer to you that it's not in there, yeah.
Anyone else? Susan?
Thank you, Madam Chair. So I'm aware of another program similar to the way Linda is. I serve on a federally qualified health clinic board, and the Department of Corrections has engaged the healthcare clinic to provide, and the name of the drug is escaping me, but it has to do with addiction, the drug for addiction. So would our substance abuse program provide those same services? Would we, I don't know if I'm in conflict here or if they kind of go hand in glove, or I'm just trying to assess that and know if I'm, if we as a community agency should be providing those services, or if there would be any coordination with both that, that treatment program, that physical addiction treatment program, and this service?
I think you're a little bit ahead of the curve in a good way on this, because
Okay.
what is coming out, to answer your question from my vantage point, is that there's currently ongoing discussions with the Michigan Department of Corrections and the PIHP directors relative to ongoing substance abuse services at the point of discharge, including those who are on methadone, need Suboxone and related medications for the aftercare after they come out of MDOC. So that is forthcoming. And I don't believe, and I could be wrong on this, but I don't believe that the substance abuse services that you're speaking to are currently available through that PCS contract. That's more on the mental health side.
Okay.
I could be wrong on that, but what is coming, and I will bring back to the board soon enough, is an agreement, and Kimberly's working on the agreement right now with MDOC, and Randy has taken lead as the coordinating agent with MDOC and the PIHPs to offer that very same outcome that we have active MAT, medicated assisted treatment services at the point of discharge.
Okay. And so there's no conflict in this program. I just want to make sure that I'm not.
No, I don't see that. No.
Okay. And I also, I'm an advocate. It doesn't matter to me who provides the service as long as the recipients are getting the service. I just want to highlight that and think that it's a good coordination. It's a good program. So, because it helps the recipients. So let me know.
Either
when
way,
that
we
comes
would be
up.
the provider, either through PCS, if it extends itself that far. I'm not certain it does. But in this other initiative I'll be bringing to the board in the next few months, that certainly is something that they're going to reimburse us for.
Okay. Thank you.
Thank you. Seeing no other speakers, all in favor signify by saying aye. Aye. Opposed? Motion carries. Next is item number 7A, receive and file the Clubhouse Medicaid Spend Down Grant from the Michigan Department of Health and Human Services. Motion to receive and file by Mr. Birdie, support by Mr. Kraft. Could we just get a brief overview? Get just a little update. Commissioner Flynn wanted, every time she sees Clubhouse, she wants something said about it, so.
Yes.
Let me do it?
Could I have Bruce come up
Sure.
to give us a report, our director of Clubhouse? He's doing such a fantastic job. I know he wants to brag about.
Thank you, Joan. This was actually all the thanks goes to Mr. Kinch for bringing this up with the department. For clubhouses in Michigan, standards 1 and 2 indicate that anybody with a diagnosis of mental illness is eligible for clubhouse. However, in Michigan, that's not the case. So when clubhouses in Michigan go through their accreditation process, they always have to respond to what is your action or what is your plan to re-engage all members or people with mental illness as it relates to Clubhouse and inviting them to be members. John brought this up to the department as issue because our Medicaid deductible folks are not actively engaged in Clubhouse. That ended up in the department taking a look at some grant dollars that they had and using those grant dollars and inviting PIHPs to actually provide a proposal to how we would reengage this population. The department has out of the 9 or 10 PIHPs in the state, only 4 across the state responded to the department for this opportunity. And like I said, that would have never happened if it hadn't been for Mr. Kinch and bringing that up for the department to take a look at. With this grant, it allows us to reach out to our Medicaid deductible members, re-invite them so that they can re-engage in Clubhouse, so that they can get all the supports and services, stability, help and stability, recovery, all of those things that are the foundation of Clubhouse for ongoing mental health, a service that acts in a way that provides stability and less recidivism for that group. Not only that, but it also allows them to manage their health care services as well, because as you know, once they've met their Medicaid deductible, they can go to the dentist, they can go to the doctor, they can, have their podiatry needs taken care of and things of that nature. So it's just a wonderful, wonderful grant, and this was a collaboration between not only Crossroads Clubhouse, but Friendship House and many other people at the administrative level. So we're grateful. We're very grateful. Mm-hmm.
Thank you. Okay, all in favor signify by saying aye. Opposed? And next, motion carries. Next is receive and file the MCCMH fiscal year 17-18 mid-year status report. We get a motion to receive and file, and then we'll have a discussion. Motion by Kraft, support by Flynn. All right. You want to take that?
Yeah, certainly it's that time again every quarter where we need to pay particular attention to where we are relative to revenue and expenses, our Medicaid, our Healthy Michigan, and our general fund, our general fund statements. And so on May 31st, Cindy Mack submitted to the department our mid-year financial status report. And so in the usual and typical fashion, as she's presented it as an executive brief, Cindy wants to run through the executive brief with you again to include, like I said, Medicaid, Healthy Michigan, and also general fund too. So, and as she goes through it, give her the opportunity to go through it, and then afterwards we'll take some questions. Go ahead, Cindy.
Thank you. In your packets, as John mentioned, it is in the standard format. Based on some additional information and detail that I've added, the only difference you'll see is I just changed some of the formatting. So whereas you would be used to seeing Medicaid and Healthy Michigan on one sheet, you will notice that there's a separate sheet for each one of those. Other than that, it's in the same format. So what I'd like to do is first just run through where we ended with our mid-year status report that was submitted to the state on the 31st of May. Looking just at our Medicaid for fiscal year 17-18, we started out with an ending, or the ending balance where we ended, I should say, for 16-17 was $9.3 million for our Medicaid. So when we take that, we're taking our revenue that we're projecting. Again, this is a mix of actuals and our projected for the year. Our revenue, we're looking at $166.3 million. We add to that our substance abuse of $3.9 million for a total projected revenue of $170.3 million for Medicaid. On the expense side, a mix again of actuals and what we call expecteds, what we expect to be receiving at the end of the year and hitting with our expense is $179 million. Again, adding in our substance abuse figures of $3.3 for a total expense projected at $182.5 million. With that, we're looking at a deficit of $12.1 million on our Medicaid side. On the report, when we report it to the state, our mid-year status report, we need to show how we'll cover that deficit. So with that, what we needed to do is we moved some of our Healthy Michigan with a redirect of a little over $1 million. We also drew down from the ISFs, both the Medicaid and the Healthy Michigan. So we took the 9.3, which was our beginning ISF, along with some of the Healthy Michigan ISF, the 1.2. We also took some funds from our local of 1.1 in order to cover that deficit. And with some calculations in there and some things from substance abuse, we actually close out with a slight surplus of $593,000. In summary, there at the bottom, you'll see again the effect on the ISF. Again, it started at $9.3 million. We did the redirects, which totaled actually 1.7 once we did that in conjunction with the HMP, which you'll see on the next page, for our ending ISF balance to Medicaid of 1.6. What I'd like to point out is those projections do not include a few items. As we've been asking for the 7.5, my understanding is that we've been in receipt, or we will be in receipt of $1 million, and they're calling that a Michigan Enhancement Grant. The difference with this is when we received the $5 million, we were instructed that it came in as general fund and what was specifically used to cover the Medicaid ISF. With this, my understanding is there's some question on how we'll need to report that, and we'll speak to that later. I believe John might have some information as well, and I think we're still waiting for additional. Also not included in this projection is the $1.6 million projected savings that was just recently approved on our MORC rate reduction. So we should see that in our next report as well. Lastly, for the last quarter, we have a new update from Milliman, and actually that's changed, and we'll be speaking to that at the end of this report as well, that for the last quarter, there were some rate reductions. However, from June 12th to just this week, there's already been some changes. When I submitted this up on BoardSync, I had noted that it was a 7.8 increase that Macomb would be seeing. However, as of this week, I've seen that now that has come down to a 2.5 increase, 2.5%. So on the Medicaid side, when I separate that out, it's roughly about $1 million that we would be seeing just for the fourth quarter. And again, at the end of the presentation, I'll get into some more on that. Moving on to the next page for Healthy Michigan. We began the ISF with $1.2 million. Our revenue is projected for CMH to be roughly $12.4 million. Substance abuse at 6.4 for a total of 18.9. Our Healthy Michigan expenses we're projecting to be 11.4 million. Substance abuse 6.2 for a total of 17.7, giving us a surplus of 1.2 million roughly. Again, from what I spoke to on the Medicaid page, we did some redirects. So moving over that ISF original 1.0 to cover the Medicaid deficit, we're taking that out. There were no carry forwards. And then we did another redirect from the Healthy Michigan ISF, again to cover that Medicaid deficit of the 1.2. We moved and redirected from our local funds, 1.4, leaving us a surplus of 236,000 roughly. Again, summarizing the effect that has on the ISF, we redirected that 1.2 original starting balance. We added in what we're redirecting from our local funds, giving us an ending balance for Healthy Michigan of 1.4. And again, on this, the projection with the new Milliman rates with that 2.5, when I look at the Healthy Michigan portion, we'd be looking for the last quarter of an additional roughly $368,000. Moving on to the combined Medicaid and Healthy Michigan then. Our combined ISF balance, which is how we do report it to the state, started at 10.6 million. Our combined revenues, 178 million. Substance abuse, 10.4, for a combined $189.3 million revenue. Our CMH expense combined, 190.6 million. Substance abuse, 9.6, for a total of little over 200 million, leaving us a combined deficit of 10.9. Taking into consideration all of the redirects, what we drew down from both the Medicaid and Healthy Michigan original ISFs, along with the redirects from our local funds, it leaves us with a surplus we're projected at $829,000. The effect on the ISF combined from the original 10.6, drawing down from local, leaving us a combined ISF of $3.1 million. And again, if I can just point out, this does not include the $1 million that we're supposed to be getting as far as the smoothing per se. Again, not knowing how we're supposed to be booking that, whether it'll be general fund or Medicaid, we're still unclear. Does not include the MORC rate reduction that we should see of roughly 1.6 million. And it also does not include yet this rate increase by Milliman. But again, we thought it was 7.8, but we just now found out it's 2.5. If I can move on to general fund. Our general fund expected revenue is 10.5 million. Our total expense we're projecting to be at 11.5 million, resulting in a deficit of a little over 1 million. We again redirect funds from local to cover that because we cannot, again, when we report this to the state, show a deficit. As far as the expenses and looking at the general fund, again, we're continuing. We're in budget process right now. We're analyzing what's going on through the year, looking at the agencies, looking at the programs. What I can point out is what we're looking at, we're seeing an increase significantly in some local inpatient spending of over $800,000 are included in those projected expenses. And then we're looking at year to date right now, it's about $700,000 actual general fund going to the UBHC. And then there's some miscellaneous things in addition, but those were the two key factors. We also are covering more out of general fund because of the DAB-TANF migration. Anything because that benefit package remains the same, all under Medicaid. Anything that we're providing and it's not getting that higher rate is coming more out of our general fund. The only other thing I'd like to leave you with is what I referenced was the draft from Milliman, and I can pass this out, and I believe John then will have more to speak to it. Last week, June 12th, the draft that came out referenced Macomb getting a 7.8 increase for the last quarter of 2018. And then as of this week, and I was on a rate call yesterday, they did revise that, and Macomb, along with some other areas, were drastically brought down from the original draft, and we're now at 2.5, resulting in obviously a less realization. Basically, if we annualized it, when I looked at it, it would have been a $17 million if we move those same rates into 2019, where it takes it down to roughly $7 million increase. So we lost about $10 million from their drafts. And I'll pass that out.
Thanks, Cindy. Stand there for a minute. There are probably going to be a few questions that the board may have, but if I can just take a minute to embellish a little bit further, aside from what you may have in the way of questions relative to Medicaid or Healthy Michigan or General Fund, I think it's important. I sit here and I think it's surreal. It's surreal to talk about the shifts of millions, tens of millions of dollars in the course of 24 hours. We, as we all know, and I'm not going to say any names, and I don't want to. It's going to sound like sour grapes. It is sour grapes on my end, because we 2 years ago didn't believe that the redistribution, the Medicaid rebase, was fair to Macomb, and we fought that fight alone. This board and myself and the administration, we fought that fight alone. We went to the legislature and we fought that fight all by ourselves. The other PIHP directors, the board association, nobody jumped in to say it's not fair. Okay, so that's the end of my sour grape story. Okay, so what happened here is that when we sent to you, and I sent to you a week ago Friday, the state fiscal year 2018 amendment in a PowerPoint presentation that was dated June 12th that said we were going to receive 7.8% increase in 18 and then in 19. And what happened yesterday, and what happened is that some of the folks who advocated hard for smoothing in the rebase got a hold of the attention of the board association. And I'll just leave it at that as the board association. The board association went to bat for those folks, those others, community mental health services programs, who were not being equitably or fairly, funded, fair. And what they did was they influenced the department yesterday in a rate setting meeting. And so you get the big picture here. In the course of that one meeting, it's still out in draft, we were caught in a crossfire of $10 million. And it's surreal to sit here and say that and to think that. But we were supposed to get, as Cindy indicated, we were supposed to get $17 million in rebase. And because of the board association's involvement, and again, my sour grapes, because they weren't involved with CMH 2 years ago, because of their involvement, they persuaded the department, and it's still draft, waiting to come out. It's going to come out because our rates take effect the 1st of July, that the board association partnered up with those poor agencies who didn't think it was fair. And what happened to us was a $10 million reduction from what we should have received. As Cindy indicated, we should have received $17 million in 19 annualized, and it's $7 million. And I think that from your perspective as a board, you can drill down to the nitty gritty, the detail of UBHC and some of those things, but I think it's just unconscionable that we sit here as a board and take a $7 or a $10 million, not really a reduction. You don't realize that you get $7 million, good for us, but you don't get the 17 that was in the original projection. And obviously my crosshairs are on the board association. Wayne County, I won't speak for them, but I did speak with Willie. They took a $17 million reduction. The UP took a reduction. The entire UP region took a reduction. And region number 4 over on the southwest part of the state all took a reduction. And we don't think there's any fairness to it all. And so it's still in draft form. But I'll tell you what, as a board member and in favor of our consumers, if you know the board association, I think it's worthy of a phone call. And you're going to probably hear lots of rationale why it is what it is, but it's worthy of a phone call. We do pay dues. We pay $20,000 a year in dues to the board association, and I cannot tell you how unsettled I am based on what happened yesterday during that phone call.
Well, I think we should withdraw from the board.
Did you have any more on that?
No, I think we'll take questions.
Okay. I have Linda Bush on as speaker, first speaker, the only speaker. So put your name on if you want to speak.
How do
Linda?
you put it on?
Go back to the agenda, the cover part to the agenda. All right, Linda?
Well, last point first. It isn't mine. Last point first is, I don't think we need to call the association. I think we need to have a meeting with Bob Sheehan. Have him come to here. Have him come to but, he comes to our regional meetings, he can come to a smoothing meeting, a meeting to, tell us what happened rather than a phone call. In terms of this budget, this isn't, for me, full board is not a good place when it's a crisis and critical, and it changed from a, the last we were told was that we were in good shape for the year. And, you know, I understand the dilemma of how things change. So I would like to, like in the future, maybe that we have a finance meeting or something to have this explained, where there's a whiteboard where we can, you know, Cindy doesn't have to stand there and talk to us up like this, where we can ask questions better and have it presented, because this is, I'm not understanding all of this. The other thing on the third point, on the general fund and the UBHC, are we getting a report on UBHC separate from this tonight? Okay. Because that was part of what UBHC was supposed to do, was save costs on the inpatient part, where you say that there's an increase. So for it to, UBHC to cost us more money, if our inpatient costs to go up, is, you know, a reversal too. But that's all I can say, because I don't really understand all of this tonight with at first glance, so, thanks.
Well, I agree with Linda. I always have the fact, the only thing I know about money matters is money matters. And if we lose that money, I can't understand why the board doesn't stand behind us. What are our, don't we have representatives on the board that find out what's going on up there besides you, our director? We should have more clout than what we have up there. Something's got to be done. Maybe Linda's right. We should have them come down, explain it to us. You mean to tell me, John, you were fighting that battle and they weren't behind you? They weren't behind us? I thought the board was always behind us.
Well, I don't want to air dirty laundry here in public, but I, you know, emailed Bob a couple weeks ago and I said, what's the end result? You know, what are you looking for here if you want to engage the discussion with the department on the fairness relative to the rate setting redistribution? Where was the board association 2 years ago? That's my issue. My issue is, where was the board association 2 years ago? And, you know, you and I, we did it on our own. You know, we know it's not fair. And we did it on our own. And so I need to bury this issue with my own mind, that I think that the board association has gone to bat for other community mental health services programs, and in the ripple of that, and ripple is an understatement of that, it affected us to the tune of $10 million. Because we were at 7.8. We were at the largest percentage increase.
Yes, yes. Well, I'll call him tomorrow.
Thank you, Joan. Next is Lou. Lou?
What is the formal title or the line item where that 17 million was to come from?
It's in a PowerPoint presentation that I sent to you a week ago Friday, not last Friday, the week prior.
I remember that, but frankly, I don't recall the specifics, because if I'm going to talk to Bob Sheehan tomorrow, and you're damn right I am, I want to know exactly what that line item is.
Well, it's the state fiscal year 2018 Medicaid amendment. I don't have that right. I don't have it in front of me, but it's the state, and it was dated June 12th. So it was presented in Kalamazoo. A number of my staff are in Kalamazoo. They understood it. You know, they understood the specificity behind it.
So if I were to say that we were projected 17 million from the state fiscal year 2018 Medicaid amendment dated June 12th, I would have an accurate reference. Is that correct?
Correct. These two sheets that Cindy passed out, the one is what we thought we were getting on the back page, right?
I see that.
And then the one that they're gonna go with, and it's tentative yet, but, that's the direction. When you hung up the phone, they said, we're gonna go with the 16 or the other one, and that's the one on the front page where it says 2.5%, correct, Cindy?
Correct. And if you do reach out,
It's the two-page handout that,
No, it's the one that Jim just handed to us.
so the one on the back was this 7.8%. That's equivalent to 17 million. The one on the front is 2.5, and based on data analysis, go ahead.
all I was going to say is to clarify, the 17 million is what we had to take. We get a revenue file each month. So what we had to do is take that 7.8 and apply that to what we had as far as our projections, as far as enrollee count. So they wouldn't see, we had to do that and come up with the 17 million. We just applied the 7.8%, and then I annualized it for what it would be into 19. So we had our quarterly figure, and I would be more than happy to share what the exacts are on that in a spreadsheet form, but it was annualized for 19. But it was done on the enrollee count, what we've had up to this point. We don't have our revenue file, obviously, for July. We had just the projected amounts, and we applied 7.8, and then we did it again now with the 2.5 to see what that difference would have been. It would have been at 17 million versus now 7 million.
No offense. When I talk to Bob and I say, what time is it? I don't want him to tell me how to build a clock. So what I'm saying is, I just want to specifically indicate to him that I'm unhappy about two things. 2 years ago, when we took a $43 million hit, the silence from the state association was overwhelming. And now, when we were to get a $17 million recovery on the benefit of their going to bat for 4 units, we now take an additional, $10 million cut on top of the 43. So I'm unhappy about two things. I happen to serve on the executive board, and I serve on the steering committee, and I plan to tell him how unhappy I am about both of those instances and how he happens to place Macomb County in a secondary position. That's unfair, it's unacceptable, and I plan to tell him that directly. So, no offense, when I say what time it is, Bob, I don't want to listen to him telling me about a clock. I want him to just clearly understand how unhappy I am on the basis of the lack of support of the state association. Period. And him counting on my vote and influence may be difficult in the future for him. And trust me when I tell you, he counts on it.
Thank you. Linda, you had something else?
The 17, it's not really a cut. The 17 million was, for rebasing, was kind of a windfall. And now our windfall isn't going to be 17 million, it's going to be 7 million. Is that the
Correct.
better way to explain it?
Correct.
It's not really, but we're short 10 million anyway, so we could have used the 10 million. I'd just like to say that the word on the street is that Macomb has done a good job and doesn't need so much money, and these other places are broke, and they need to be bailed out, and that's kind of the politics of this.
Absolute nonsense.
That's the word on the street. Did you want to be true? That's just the word on the street. That people are saying that our ISF is the highest in the state, but it's all happened. The problem is they have us fighting over not enough money. The legislature doesn't choose to fund mental health and the services that the people need at the proper level, so they have us all fighting with each other. And that's my statement.
Okay.
Chairman,
Yes, Lou?
for the record, that's not an accurate statement, Linda. The legislature has appropriated dollars. The State Department has not distributed the total allocations on an annual basis. So if you make a statement like that, you're going to fall into a pothole by saying that the legislature isn't making the appropriations, when in reality they have been, and the State Department chooses not to make the distribution. That's the problem. It's not my opinion,
All right.
it's the facts.
All right, let's move on. I think we're all on the same page in terms of we don't like what's going on. And let's not get bogged down in some technicalities. We need to use the right terminology, but we will get that. I have Susan, you'll be next, but I just want to make a comment again, just to clarify. Again, we are getting an increase, but it's not as much as what we thought we were getting based on the report from a couple weeks ago. Is that correct?
That's correct, Jim.
All right, and then the other PIHPs, everyone's getting an increase, but some are just getting a higher rate of percent. No, actually, some are getting a total. I'm looking on the wrong sheet. Everyone's getting some kind of an increase on this one, right? On this newest report.
If you look at it, I think that just the best way to summarize it for the board is the four PIHPs who were most affected by the call yesterday negatively on amount of revenues projected to receive in 19 was Macomb, Wayne, region number 4 over there, Brad Casemore's region, and the UP.
Mm-hmm. Thank you. All right, Susan?
So I'm looking at this and I'm saying I agree with what John just said, but I'm looking at it and saying who got hit you said who got hit the hardest, and I'm looking at it saying who got the most, right? Who is the association answering to? Because to me it looks like they're answering to Oakland, CMH Partnership of Southeast Michigan, and Mid-State Health Network. They're the ones that got the most money, right? So I think that's whose voice they're hearing, and so that's what we need to call them out on. Yeah, CMH of Southeast Michigan. I can only assume that that's a community south of Detroit Wayne, right?
That there's Washtenaw, Lenawee, Monroe, and Livingston County.
Yeah. So it's the wraparound of Detroit Wayne. So, I mean, I think we better start looking at a few things and tracing some things, right? Let's start tracing some policies and find out, I don't know, doesn't the Board Association take donations to the PAC, and where's that money coming from, and what's it being used for, and who's donating, and let's find out, because let's face it, this is politics, right? And it doesn't matter what the facts are. It does, I shouldn't say that. I take that back. It matters what the facts are, but as we all know, perception is reality. So if people think that we have been able to stomach these cuts and manage this, then that becomes the reality. Whether it's true or not is a whole different question, right? If the word on the street is that, Macomb's got a big ISF or whatever, that we've managed this, then that's what they're hearing and that's what they're going to act on. So, I'm frustrated with this as well, but I'm getting to the point where I want some hides out of this. And I think I'm hearing that from you, John, too. I won't say it as
I didn't want
succinctly
to
as
jump
you
out
did.
of turn here and comment. I was going to comment later, but when you talk about the word on the street that, we're financially better off than others, that's a pretty shallow statement to make. Every one of my administrative staff need additional support to be able to fulfill their jobs. We have 80 vacant positions that haven't been refilled. The providers out there, Buddy Smith and the other ones that's in the audience that spoke up tonight, they're still operating on 2015 rates in a 2019 marketplace. Our acute psych providers are still working with a 12% rate reduction. The CLS that we've cut to all of those people, none of those services have been restored. So I think it's a very shallow and unkind, unsensitive statement to make that our finances, that we're fine. but look at what we've gone through.
So I don't disagree with what you're saying, right? We all know that. You are preaching to the choir here, right? The perception is somewhere, based on this, the perception is somewhere out there that what you just stated, they don't know that for whatever reason, or they don't care, right? I mean, there is a perception out there, apparently, based on the numbers here.
Like, what did Canfield tell you? We got all the money.
So, I mean, you know, like I say, I agree with everything that you said, that, you know, our recipients are hurting and our staff is hurting, but for some reason, they don't seem to understand that. The powers that be don't seem to understand that. So I agree with Linda. I would like to have these people, the board association, come here and justify this in person. And I don't know how we pay them. I don't know if we get invoiced monthly or quarterly, but I've already spoken, so I can't make a motion, but I would certainly support a motion to put that on hold for a moment. Thank you. Okay.
And it's a single payment check. We approved it several weeks ago. And we do it once a year when it comes up. The dues have been paid. So withholding it is a consideration for next year.
Are you on the list?
All right,
Thank you.
let's
You're speaking out
let's
of turn.
put our name on the list if we want to speak. There's and again, to make this clear, another clarifying question, I guess. This rate is from the department, correct? Not from, the money's already been appropriated by the legislature. The legislature doesn't decide, has not decided who gets it. They're just giving the large amount to the department to disperse. Is that correct?
Correct. Goes through the actuary.
Right. So none of our, the legislators who maybe think we have something, if that was something I heard, perhaps a reference to that, they need to be informed as well. But that's not where this problem is. The problem isn't lying there with this particular thing. Just based on what we have right now, it's not based on that. But they could perhaps do something about that in their policy.
So I didn't mean to imply that the legislature had
No,
anything to do with this, yeah. I'm speaking strictly of the board and the department.
Okay.
Thank you.
I have Commissioner Flynn.
Through the chair to Lou, can I ask when was the last executive board meeting? Didn't you know any of this was coming? You go there every month.
Joan, could you repeat that? I'm not hearing it clearly.
I asked, what were you doing? You've been up there for a year now, the executive board. Didn't you know this was coming down with Bob?
This was never discussed on an executive board agenda in my recollection. And last week, I was at the steering committee, and it was not discussed there either.
That's what I
Period.
mean. There's
It
something
was-
wrong up in the high up ups.
I'm just saying it was not discussed at last week's steering committee, and it was not discussed at any previous executive board meeting that I can hear. John attends both of those usually. Is your recollection the same as mine?
This issue hasn't been an executive board
Thank
issue.
you,
no.
John. It has not. Or I would have made an issue of it at that time, and so would John.
Thank you.
Oh, seeing no other speakers, I think to just summarize this, I think a letter, a phone call, whatever is probably in order, just stir things up. We can make some other decisions if we want some type of resolution or other action. I'm thinking right now to withdraw membership, it's $20,000 compared to our entire budget. It's not that much money. And then if you withdraw your membership, who are you going to talk to? We're not members anymore. So we have to consider that as well. But we can think of some other way to get that message across in a way that will cause them to pause. and
Point of
reconsider.
information.
Madam Chairperson,
All right, just,
may I make a comment about that?
yes.
Withdrawing your position is negative. not paying your dues when the bill comes is a loud voice. And other boards have in the past historically not paid. Their membership is not immediately terminated.
Okay,
So what I'm saying is, rather than terminating your relationship with the board, when they present the bill, we hold it under advisement for evaluation. We're still members, we just haven't paid the dues. That will get some attention, I assure you.
But it's a year out.
all right. Thank you. Susan?
Are we going to ask them to come and present at our next board meeting?
They're going to be at the Metro Region.
Pardon?
They'll be at the Metro Regional
Okay.
Dinner, which is July 19.
Is that the forum where we ask them to come
We
on
probably-
mic and justify this?
We-
Well, Oakland will be there, so will Detroit Wayne. Oakland made out, Detroit Wayne didn't.
Right.
So maybe if John does a
So-
little talking before the meeting, that might be interesting. Unfortunately, the dinner is after the July 1st effective date. Sadly, it's an after the situation. That's why I'm going to call Bob Sheehan tomorrow and tell him how unhappy we are about the present situation. And frankly, it's going to be a long-lasting unhappiness.
So, okay, then can't we call a special meeting and ask him to come here?
Sure you can.
Let's do it. Absolutely. I want him to stand here on mic, and I want an audience full of people. Thank you.
We have program and budget July 11, Wednesday, July 11. I'm not sure we can pull something together before that, but that could be one of our targets. If not, a special meeting would be in order. So, John, can you work on that?
Sure, let me think about this for a day, and I'll get back with the board for a Friday morning update, and I'll talk to Bob too.
Great, thank you. Anyone else on this particular issue? All right, then, all in favor of receiving and filing the report, do we have a motion? Yes, we have a motion. All in favor of receiving and filing this report? Opposed? All right, thank you. Next is a resolution for retirement for Sandra Luther. Motion by Birdie. Support by O'Donnell. Oh, O'Connell, sorry. All in favor signify by saying aye. Opposed? So Sandra Luther's retirement has been approved. And next is item number 9, voucher listings. Motion by Birdie. Support by Doherty. Any discussion on the voucher listing? All in favor signify by saying aye. Opposed? All right, next is the management report, and I think that we'll have a few more items.
Sure, I'm going to
for
run through my
discussion.
piece real quickly, and I'm going to turn it over to Jim for some of the interest the board has. As far as your calendar is concerned, July 11th is our Program and Budget Committee meeting here at 6 o'clock. July 18th, we have an ORR appeal meeting. Is that an appeal or advisory meeting?
July 18th is what?
Recipient rights. It says appeal. Is that advisory meeting? Appeal. July 18th, 7:30 in the administration building. July 20th is our advisory meeting, 7:30 in administration. July, pardon me? Yeah, full board. Whole of the board, I mean. Yeah. Regular full board meeting is July 25. The Metro Region dinner meeting that we're hosting is the darndest thing to pull off this time. And I'll defer to the board on this. We were going to have it on June 19 in Oakland. It was originally scheduled for June 19, and Oakland didn't have it on their calendar. We scheduled it a year ago and didn't have it on our calendar, so they were no-show. So they were going to be a no-show. So in good faith, we decided we would move it around, and in my efforts to work with Macomb, or Oakland and Wayne, we settled on July 19th, and for whatever reasons I'm not going to go into, it doesn't sound as though there's a mental health association, Medicaid health association meeting on July 19th, and so it doesn't sound like the CEOs are going to be there. Perhaps Willie's not going to be there. Annette Downing is the new CEO. I think she takes effect in Oakland County. I tried calling her today and wasn't able to reach her. So Willie's not going to be at the Metro Region dinner meeting because he's going to be at the conference. And I'm curious also, what would the board want on the agenda? I don't think it's the proper forum to address the board association. I don't think it's of our benefit to spend any time talking about 298. So two things: we could either one more time potentially cancel that meeting and push it back into August or September, where we get Oakland and Wayne committed to attending along with their CEOs, or we can have the meeting on July 19th. I just don't want you to be disappointed when we get there that we all sat down and had a nice dinner.
August. Linda supported.
Okay, right now we have a motion on the floor to postpone the meeting. The Metro Region meeting, yes. From July 19 to some date to be determined in August.
Yeah. So I apologize for that, and Barb,
That's
does a
okay.
lot of work sending out notices to get everybody on board, and she's already got reservations made, so it's more work on Barb, but I apologize for that. And so we will go with, did you vote on
We
it?
didn't take a vote, but I think
Okay.
without objection, we'll
So
change that.
August or September, we'll try to get the whole of the Metro Region involved. Also for your calendar, December 12th, we've been advised by the Board of Commissioners that the December 12th meeting, we're getting booted out of here, and so the recommendation to the board to move that December 12th meeting to either 11 or 13.
No, December.
December.
So I'll defer to the board, 11 or 13.
Might as well have it on the 13th. Sounds good.
Is it? Yeah, Tuesday or Thursday on either side of that. Does either one work? We're talking about December,
Yes.
moving it to 11 or 13.
Do you need a motion?
Let's just take a little poll here. First of all, it doesn't matter what day we pick.
Doesn't matter.
All right, how many prefer the Tuesday, the 11th? All right, so I take it most of us approve Thursday, the 13th, we prefer? All right, that's what it'll be then. 13th, Thursday, the 13th.
Okay, so December 13th, thank you for that. We'll make the adjustment. And then a couple more things. We had to write a response back to Diana Farrington on that $1 million, and Cindy alluded to it tonight on where that money's going to land. We had been lobbying for that money, that $7.5 million to go into our ISF. That that $1 million that we received is just a grant, and I believe the department is looking for us to return that to services. So what I had narrated today and sent back to Diana Farrington was a state budget report that goes to the budget officer that more and less spoke to. I didn't have time to print it and give it to the board. I'll give it to you Friday, I think. That since it is a a grant in the tune of $1 million that I include, and since we are responsible for general fund and the public safety net, crisis and emergent services, I indicated in that grant that we will use that for the crisis center operation, and we're also going to use it for urgent behavioral health care, defraying some of those costs, and for acute psychiatric inpatient treatment costs. Those where our GF costs are running high. And so it's my understanding, don't want to get ahead of myself, but when we submit the budget in July 11th, you're going to get the budget. Cindy's going to send it. We have to send it to the county executive. It's my understanding there's not a lot of leftover general fund dollars that the county has offered up before. And so we need the money to continue to sustain the crisis center staffing and discretionary funds for the crisis, or for GF as well too. So just so you know, and when Cindy presented, we don't know if we're going to get those dollars in Medicaid, that grant, or whether it's going to be actual general fund. So I'm kind of trying to paint a path for use either way. And so at some point in time, Cindy's going to get an email and it's going to say, here's that $1 million grant, and it ends up on the Medicaid side, or it's going to end up on our state fund side. So we'll let you know where it's going. But I think we have our bases. I think we have our bases covered in that regard. And then, you know, I'm pleased to hear, you know, Susan say, whose voice are they listening to? Because that's what it's about. You know, whose voice they're listening to. And I'm thankful to all of the board and the staff who are working on this. You know, I'm just really unsettled by it. And thankful to Lou, because you're spot on. You know, when you talk to whatever the board association says back to you, you have two very valid points. 2 years ago, there was no support. And this year, you know, whatever support the board association threw at whoever else it was a double whammy for us. Then I'm going to turn it over to Jim. Thank you.
I have two reports, one on the UBHC, and I'll start with that one. And I'm going to ask Sheila to come up, and she'll fill in the blanks for me on some of the operational issues related to the UBHC. Just a second for the materials to get around to everybody. No, the second one. Oh, both that are going around right now are the same, yes. The second one. Okay, the UBHC, as you'll recall, was implemented a few years back to address. Oh, I'm sorry. UBHC was originally implemented to address the inpatient admission crisis that we were experiencing, where we felt our inpatient admissions were too high, and we felt that a program that we could implement that would provide a hold, intervene, divert attempt, and an attempt to return the consumer to the community as opposed to going to inpatient admission was a strong program to accomplish that goal, to reduce inpatient admission. We modeled our program after Common Ground, as you'll remember, and had some consultation with them. Subsequently, we discovered that there are some restrictions in terms of what kind of facilities can do that kind of work. And that was a major factor in the volume that was able to come through the UBHC. So since then, we have looked at evolving that model from that hold and intervene and divert model to a model that really talks more about open access, faster access to services, as opposed to somebody calling the access center, getting an appointment 2 weeks out to come in for an intake. We're able to offer a much quicker response to that, where we can send them over to the intake center, to the UBHC, to receive a same-day or next-day service, which is valuable to the consumer in terms of their ability to quickly get a response to their needs, especially if they are in some degree of crisis. So the goals of the current implementation of the UBHC are to address consumer care needs following hospitalization and engage consumers post-hospitalization. Sheila will talk in more detail about that in a moment. But we're looking to reduce waiting time between the request for services and service provision. We right now have a open access where folks can come in between 8:30 and noon, Monday through Friday, to receive an intake. They can either walk in or they can be referred by the Access Center. Somebody calls the Access Center and says, I have a need. They can refer them directly over to the UBHC, where they can walk in that day or the next day or the following day to receive immediate services. The advantages of that, and again, Sheila will go into more detail, is consumer engagement. You're obviously able to meet somebody's needs much quicker, and you can be much more responsive to the community in terms of what needs are being presented out there. The second goal is to address consumer care needs post-hospitalization. Right now we've got a pilot going on with Henry Ford Hospital where we're actually transporting people from the hospital at the point of discharge, bringing them right over to the UBHC. We're able to provide services to them directly in terms of an intake to get them open in the system. We're providing case management as well as medication services until they're able to connect with the providers that they're either previously enrolled with, or if they're a new consumer, until they're able to connect with a provider that has capacity to provide psychiatric services. So it creates kind of a bridge between the point of discharge and the beginning of a regular service provider, because we felt like people were falling through the gap there, and we were having people experience a return to the hospital because they weren't receiving services post-discharge. And so this gets them in to carry them until they're able to be connected with a regular provider. We're also in the process of sunsetting the EPE contract at Henry Ford Hospital, the Emergency Psych Evaluation contract. Right now, they kind of provide on-demand medication review services for us. And one of the things that happens when the consumer goes to a hospital for that kind of service is the staff there don't know the consumers, and so therefore they conduct a psychiatric evaluation, and there's a facility charge that goes along with that. So you've got extended costs that go into that med review. What we want to do is to take that service and bring it in-house, operate that out of the UBHC, and provide those services to consumers that would have normally gone to EPE. And we would save both the psychiatric evaluation cost and the facility cost. So we'd be looking at more like $100 instead of $500-600 per service that's provided. So that's where we're looking to go. That's where we're at and where we're looking to go with the UBHC in terms of a model. I want to turn it over to Sheila, who's going to give us a little bit more information on the same-day access and advantages to that.
Good evening. I wanted to talk to you a little bit about the concept of same-day access. So what does that mean? It's pretty self-explanatory, right? The day that you call for services, you can be seen by a clinician or even a doctor for services. I'll give you an example. If you have the flu, most people don't wait 2 weeks to go see your doctor, right? You try to get in as soon as possible. We feel the same way about mental health symptoms. Some of them can be pretty severe. If somebody waits 2 weeks, they could end up in the hospital, or worse, not get any services at all. So that's sort of the concept of offering same-day access to people with mental illness. Without the same-day access, we schedule people about 14 days from the day that they call. We're pretty booked for intakes, so when people call in for help, they can wait up to 14 days to be seen. The same-day access model is considered a best practice model for access in behavioral health. The National Council of Behavioral Health reports that using this model will result in dramatic reduction in no-shows. Currently, when we schedule intakes, our clinicians block out 2 hours to do an intake. We have a 50% no-show rate for intakes throughout the system. So if you kind of calculate all that together, We get an estimated of about $400,000 a year in lost productivity. It's pretty considerable. So the same-day access model will reduce that high cost and loss of staff productivity. It increases, obviously, clinician productivity, increases consumer engagement. Consumers who are offered a same-day appointment show up 91% of the time versus 50% of the time. Evidence suggests that about 75% of psychiatric emergencies will resolve within 24 hours with appropriate assessment, intervention, and treatment, not hospitalization necessarily. Jim's going to talk a little bit about the cost at the UBHC.
Yep, thank you. This next slide, number 7, why are costs higher at the UBHC? As Cindy was giving her report, something dawned on me that a better title would have been, why are GF expenditures higher at the UBHC? Because costs are fairly consistent program to program in terms of what it costs to provide a service. But the amount of dollars that get charged from the UBHC to the general fund is greater, and we've looked for why is that? What's the determining factor behind that increase in cost? And at most of our programs, all of our clinic sites, services are provided on a scheduled basis, where somebody has an appointment, they come in to see the clinician, and the service is delivered. It's reported and recorded, and if they're a Medicaid recipient, which most of them are these days, it's charged against Medicaid funding source. Anytime a clinician is not providing a Medicaid or a Healthy Michigan or other payer reportable service, those costs are charged to the general fund. At the UBHC, the services in terms of walk-in intakes, the open access, even the level of discharges coming from Henry Ford in the pilot are all unscheduled activities. So if somebody doesn't show up for that activity, there's no place else to build that expense to. That has to go to general fund. And so that's why any downtime, any no-show, any service that is not captured and reported and recorded, that is billed to general fund. So any staffing costs, building costs, anything that is not charged against Medicaid or another payer goes to general fund. And that's why that number is a little bit higher for UBHC than some of the other ones, because those are largely unscheduled services. Now, if we do pick up the EPE portion of the med reviews, we will make an attempt to increase the scheduled services that are being done there and see if we can't minimize to the extent that possible unscheduled services. But that's something obviously that we need to look at and figure out is there a way that we can manage that better in order to make sure that we're capturing any Medicaid billable encounter. The value of the open access post-hospital aftercare services may be worth some level of increased cost, and that's obviously open for discussion in terms of what that level looks like. The open access obviously allows the access center to refer callers on the same day or the next day, saves access resources as well as gets the consumers in faster, promotes consumer engagement in services, reduces no-show rates. Post-discharge services engage consumer and aftercare services, reduces recidivism back to inpatient hospitalization. So one option that we would like to consider, and with the board's interest, to work with the AFIA consultant that was approved back in May. We have some subject matter expertise that came along with that contract. That part of the effort was to look at the data related to the front door. Well, this is part of the front door, and so I think it would be legitimate to have that consultant look at those numbers, look at the expenses, look at the staffing levels, look at the hours of operation, and say, is this reasonable? Are there things that we should change? And then define a target of where we'd like those GF expenditures to be, and set a hard timeline to achieve that target. And I think so service level deliverables that you've talked about, Susan, I think would go a long way, I think, to help us better manage the cost at the UBHC. Slide number 8 is the continuation of the financial data that we presented. The consumer units and revenues versus expenses. The percentages that are identified here are the revenue versus expenses percentages. We've kind of used that as a gauge to determine how much funding is going to the general fund line. And as you can see, it's pretty variable, anywhere from 151% to 385% in terms of the revenue to expense ratio. Other programs, we're currently looking at what other programs bill out for that statistic. And they range anywhere from 80%, which means that that unit is billing more than it costs to operate the program, to about 132%. So there's a fairly wide range, and I think some of that is dependent on geographic location and number of staff at a particular clinic. But I think we can define a reasonable rate somewhere in that area that can be our target to shoot for in terms of a revenue to expense ratio. And then Sheila is going to talk a little bit more about our Henry Ford discharge pilot and the successes we've had with that program. And we have some interest in perhaps replicating that portion of the program with some other hospital systems.
So in addition to the same-day access, we implemented a program or developed a pilot with Henry Ford Hospital. We sat down and met with Bruce Nestor and his team. We talked about how we can make that transition out of the hospital to a provider easier for our consumers and provide better continuity of care. So for the past 9 months, we have been transporting consumers directly from Henry Ford Hospital the day they're discharged to the UBHC. And at that time, they're seen for an intake assessment. They're scheduled appointments. They see a case manager. They may see a peer. And at that point, we start working with a provider to take them on. Oftentimes, it can be up to 2 weeks to 3 weeks before they can get in to see their provider. This way, they're not losing any care once they're discharged from the hospital. So far, it's contributed to a reduction in our inpatient recidivism from 16% to 12% system-wide. Consumers have access to post-inpatient medication services, peer services, case management services, group therapy, and therapy, depending on their need. We found that there's a better adherence to medication, and that seems evident if you turn to the next page. What we're tracking is 1 month, 3 months, and 6 months post-UBHC data. And so far, 86% of individuals that were seen by the UBHC the same day they were discharged from the hospital did not return to the hospital after a month. And then the next page shows that after 6 months, only 85% of the individuals returned to the hospital. So we're seeing an impact in recidivism, and we think it's because there's continuity of care. People sometimes leave the hospital, they get home, they feel better, they decide not to keep their intake appointment, so they end up back in the hospital again. So it's really, I think, impacting our recidivism rate. The next slide on page 12 talks about our no-show rate. So earlier I told you that our no-show rate for intake assessments is about 50% across the system. By transporting consumers out of the hospital directly to the UBHC, our no-show rate is about 9%. And those were certain circumstances, outliers, where a family got involved and met them in the parking lot and took them home. If we do not provide transportation, you can see by the chart that 54% kept their appointment and 46% failed to keep their intake appointment. So we're seeing good results with that. And then the last 2 pages is just our revised flyer or pamphlet that we give to individuals in the hospital. We have peers that meet the individuals that are being discharged. They provide them this pamphlet. They explain to them where they're going, that it's part of their discharge planning, that it's part of the continuity of care, that they're going to be engaged in services the day that they leave the hospital.
Thank you, Sheila. So are there questions that we can answer on UBHC?
Thank you. I don't, you can, I don't see any speakers right now, but I have some. Okay, you can't, you won't go on there? Didn't show up. Oh, here it is. Okay, I've got Susan, Selena, and Linda. Susan?
Thank you, Madam Chair. So I appreciate the effort that has gone into the center, because I know the objective was to reduce the recidivism and reduce the inpatient, and I know that it was, you know, I mean, I think that the work that has been done here has been Herculean in every attempt to achieve that objective. I'm struggling with some of the numbers that I'm seeing here, because I'm not sure that it's, while the intent is great and the effort is valiant, I'm just feel like I'm not getting there, right? And I feel like it's a drain on the budget, so I'm struggling with it, right? Because I want to do right by the consumers, and I know that everybody is well intentioned in their work. It just doesn't seem to be getting there. So I have a couple questions about this. Do we have any plan for how we're doing this, and whether there's ever going to be a point where we say this model is not going to function in our environment? Is there an end game? Is there an exit strategy where we say, you know what, we gave it our best, and it just either, for whatever reason, either the consumers don't want it or the hospitals don't, you know, some hospitals will work with us and others won't. The police departments won't deliver. Whatever the situation is, do we have a strategy?
Honestly, I think the model is effective, and I would put it in my other programs if I could tomorrow. I think that where we get stuck is the cost of the UBHC.
Thank
that
you.
I don't.
Right.
I don't have control over that.
Exactly.
So, yeah.
I hear you,
Yeah.
and that's exactly where I'm struggling, because we have the fiduciary responsibility, right? We have to,
Right.
you know, I mean, we all have to manage the money, but. You know, so like I'm looking at page 8 where, you know, it got pretty bad as far as, you know, expense ratio, right? Where it really cost us a lot to operate the center. And then it looks like in January we did something that caused the units to go high, right? And I don't recall exactly what that was. But now we're creeping back up to where this model, like I say, is great intentioned as it is, it's really draining the budget, and I'm not sure it's meeting our objectives.
Right. Well, I think one of the positive things about the chart on page 8 is that we can look at the services that were provided, and we have a breakdown of the services that were provided to by each staff member and number of consumers that came through and the level of each service. So we know what contributed to that better performing month. So we need to consistently replicate that month. I mean, I think if we got down to 151% for each month, we'd be heading in the right direction.
Yeah.
But
and
still, 151, which is our best number, is
Yeah.
still not
It's still high.
good enough,
And-
right? I mean,
Right.
that's what I'm saying is this, again, I don't want to take away the effort from everybody and the intent of what everybody's trying to do. I'm having a hard time from
Yeah.
a business perspective.
Yeah, and just for clarification, prior to May 9th, we were not doing the open access. So the model was still doing hospital discharges and scheduled intakes. So we were still getting a lot of no-shows up until May 9th.
Recently.
And we looked at the numbers and decided, okay, well, let's expand our open access and see if that can boost up the numbers and reduce the no-shows that we were consistently getting.
Okay.
So the UBHC, like I said, prior to that was mainly scheduled intakes. So if somebody has 5 scheduled intakes and 3 don't show, you know,
Right.
you're out.
And I think the number showing that, you know, the KPI that you're showing going from 16 to 12%, right, from the recidivism, I think is a good number going in the right direction. My question, you know, is it's a great number that you reduced it by 4%. It's a good, but what does that mean in dollars?
Right. I don't have that.
Right.
I need to
information,
know
but
what
yeah.
that means in dollars,
Right,
right?
right.
Because if I'm spending it here, how much am I saving over there? And I don't know that. Percentages, the percentage, I mean, if that cost is $100,000, that's not saving me a lot of money for versus what if it's $1 million, then maybe it is. I think
Right.
I need that number. So that's my first statement. Then the Henry Ford program, which appears to be a good, I agree, the transportation is a major issue, and I can see why that would make an improvement, and if we can replicate that with other hospitals, that would be great. My problem with the numbers are, on the 1-month recidivism rate, we're tracking 202 people, right? And we're showing, 86% or 86% did not end up in the hospital again, which is great. On the next number, when we're tracking them 6 months later, you're only tracking 107 people. What happened to the other 100 people? Or 95 people? Why? I mean, what happened to them? Did they have recidivism? Or did they vanish?
Right. They could have dropped out of services and we lost them. They could have gone on to services someplace else and we lost track of them. So, yeah, I would have to dig into that further and find out where that data.
Yeah, it just,
Yeah.
they just, the number, again, I don't doubt that the service is keeping the
Yeah.
recidivism down for those that stay in the program, but
Right.
why did we lose half of them? Why? Because those, if they were still coming to us, are again a revenue item, right? That helps sustain
Right.
the center. So
Yeah.
I really want to start looking at this and saying, I feel like we're building the aircraft as we're flying it. Which,
Sometimes you have to do that.
yeah, I know. I've had to do it myself many times,
Yeah.
but sometimes you have to reach a point where you're like, grab the parachutes, we got to go, right?
right.
I mean, and I'm starting to look at this after how many years in trying to make this work, and it's just still a very big burden on the budget for the bang that we're getting out of it. So I'd like to see more tracking of recidivism beyond just the Henry Ford program, which I think is great, and it seems to be working. If we're going to get other hospitals on, how we can project some of those savings, and I'd like to know what what dollars we're actually saving. So, because I'm spending them here, I want to know where I'm saving
Right.
them.
Right.
Okay, thank you.
Thank you. Selena?
Okay, first of all, I want to say congratulations to going to the walk-in service. 14 days out is not best practice. Anything after 7 days is a 50% drop in follow-up in their care. So that is the model that you need to go with, and it does seem to be working better. So I think that you do need to expand it out to the other hospitals in the area. Just the transportation piece and the walk-in is ideal. We need to get them face-to-face and not over a phone, because a phone call, there's no human contact and there's no commitment at that point. So you're heading in the right direction. I think that the UBHC can be a benefit by doing that, because a lot of the consumers don't know where to go, and then they don't remember where their paperwork is, and they don't know
Right.
where their aftercare appointment is in 2 weeks, and they end up in the emergency room. But will you be providing nurses at the UBHC to do long-acting injections? That seems to be the biggest thing that's coming in the emergency rooms lately, is that they can't get to that follow-up appointment, and now they've missed their appointment, so they go to their therapist, and their therapist sends them to the emergency room because they missed that appointment. So, I mean, are you
We
guys
do.
looking at?
Actually, I neglected to say that we do have a nurse on staff at the UBHC, so
Okay.
we share her with our crisis state program, so she's about half-time
Perfect.
with our program.
Okay,
Yep.
thank you.
And those are the consumers that we would be looking to pick up with an EPE-style program.
Right, so then you'll be bringing the EPE program in-house?
Yes.
And when do you think that that would occur?
We're looking at have the contract sunsetting after September.
After September? Okay. And will you be marketing? Because people really don't know that you're available. And so when I do some walkthroughs at, outpatient clinics, they're not even aware that you do have these services available for their consumers, and it's automatically to the emergency room. Okay.
Yep.
Great, thank you.
Thank you. I have Linda and then Lou. Linda?
Two questions. The cost has been really hard on our general fund budget, which has
Right.
been cut horribly. Are we doing better at billing private insurance if the people are showing up and not on Medicaid but have private insurance? There was a time when you weren't on panel.
Only Medicaid we're seeing, yep.
Is there a reason why you don't get on panel for other stuff?
I have to
I
defer
think
to-
historically we have been on some panels. I think we're able to bill some of the Medicaid health plans. Sometimes panels aren't open. We tried to get on what's the veterans one? TRICARE,
TRICARE.
yes, thank you.
Right.
And that panel wasn't open. We continue to look at that and explore it out. I'd have to follow up with finance and budget and find out exactly what we're paneled on.
And then this question is for John. John, originally, this has gone back so far, but originally, was the UBHC part of our PIHP contract for a 24/7 integrated place? And do we still have, we've changed it. It's changed so many times. It doesn't look like what we envisioned at first. So where are we with that requirement in the PIHP contract?
I think there's a lot of integrated care initiatives that are going on, and we could list them and report them out to the board. The largest one has nothing to do with the UBHC.
Okay.
That's with the HMOs, and we have a quality withhold in our contract. Performance metric that we have to do so many integrated care initiatives with so many consumers over the 8 HMOs that we're contracted with. The UBHC was a design that was, really, I think there will be more communities that will go to it. It was a design that was intended to be much more sensitive to the population that comes through. So you don't have to go to the emergency room. You don't have to go under the bright lights and be poked and prodded and those types of things. You'll be able to go to a center where you can be offered counseling, de-escalation, desensitization, having peer support specialists, psychiatrists, a case manager, those who are germane to the industry, who understand what the presenting symptomology might be, different than an ER setting. And for a number of reasons, it hasn't taken off. It's still a great model. It's the Medicaid population that we need to draw in there. So some good points were brought up tonight. I think marketing is, continued marketing, MOUs with the police departments, those types of things that would, be able to really, stiffen the program. The challenge is a lot of our consumers continue to go to emergency rooms. We can't hold people. It's not a facility. We can't hold anybody against their civil rights. If they're petition inserted, we come up against some barriers. Will it ever take off? And will ever have the patience for it? I don't know. It's a difficult climb. I know that.
Thank you. Lou and then Joan.
Where to begin? Frankly, where to begin? The UBHC concept, when proposed, was an excellent idea. And frankly, I think it still is. I'm having some difficulty wrapping my arms around this report, and I don't mean that to be insulting. it's kind of like baking cakes. It's churning over all of the facts that we know are in existence, and yet it provides no hope or remedy. Susan, I couldn't agree more with you. It's baking cakes, and it's telling us what we already know. Let me tell you what we already know. We're not attracting the number of Medicaid eligible consumers that we need to attract. This program is bleeding the general fund account toward bankruptcy. In retrospect, the conversation has been that perhaps the mistake that we made was locating the UBHC in the northern or central part of the county on Garfield. I frankly think that was a major consideration. Let me tell you what I don't really understand of where we are tonight with this report. Several weeks ago, if you recall, we had a big conversation about the fact that the present people who own the building were selling the building. And it was discovered that we were paying rent on 25,000 square feet, when in reality the building is only 19,000 square feet. I made several recommendations at that time that I thought might assist the fact that if we had located it in the wrong place, I suggested that we should challenge the present rental agreement as being null and void because of the misrepresentation of square footage. That was rejected by administration right off the bat. It was a long shot. Whether it would be effective or not, it certainly would change the tenure of discussion since the building was being sold. I thought it was a pretty good negotiating position to be in, because I also mentioned at that meeting that I had calculated that we were in excess of $300,000 so far into minor situations, and probably more, and there was a recovery of over $100,000 that we could take from the present owner prior to the sale, which would have mitigated our $300,000 plus commitment to Garfield. That was also rejected, which I couldn't understand, and I voted no, because the program was bleeding the GF line item. We were not attracting Medicaid consumers, and we had an opportunity to try and null and void the contract, and there was no intention. Administration said, no, we're going to kick the 100,000 plus to the new owner downstream. And the new owner said, oh my goodness, what a lucky break this is, because I now get a 3.5-year or 4-year existing contract with a guaranteed $100 and some odd thousand committed to me. So he did two things. One you don't know about. He said to the owner who was selling, gee, you got to reduce the price that I'm going to pay for this. And he significantly, on a real estate basis, probably made a better deal. Secondly, about 3 weeks later, there was an agenda item that said, shall we subordinate our contract to the new owner so that he could apply for a mortgage on the new building? And we voted to subordinate our contract on Garfield to the new owner so that he could get a mortgage, of which our contract being on a scale of 10, a 20, because on the first of the month, we pay our bills. So now, here we are talking about Garfield, and what I don't understand is all we're talking about is the same numbers, theoretically, that don't attract the Medicaid consumers we need, that continue to drain the GF line item toward bankruptcy, and we're talking about what we've been talking about that hasn't gotten the job done. And when I suggested 2 or 3 things that would mitigate the loss, administration rejected it, and you went ahead with the new owner, with the new building, subordinated your lease to a new mortgage, and here we are, and as Susan says, the numbers don't work.
Okay,
And
Lou,
what's the plan B? Please.
you can continue speaking, but could you please direct it toward the board or toward the director?
I'm sorry if I was pointing the wrong way. I'll apologize for that. So the point is, for the next 3.5 or 4 years, we're going to continue to bleed because I don't see in this report how that changes anything significantly. Perhaps the location might have been, in retrospect, everybody's a Sunday morning quarterback, and I was part of the decision for Garfield, I admit that. Perhaps South Warren or East Point, or maybe on the border of South Warren and East Point, might have been the preferred location, and perhaps where a branch ought to be looked at while we consider another usage for this building that might salvage what's happening. But the longer we stay here, the more money we're going to lose on GF and lack of Medicaid participation. If we don't get the Medicaid numbers up, we're doomed. If we don't get the Medicaid numbers up, we're doomed, and the GF will continue to bleed. When we had the chance several weeks ago, we refused to even blink to make an opportunity to effect a change and get out of the lease or to affect the conditions of the lease. And we don't have a plan B. So I'm saying the plan B you need, is there a facility that exists that we might locate an annex in East Point, South Warren, the border? Is there a facility that we might be able to do that, that might be able to attract the consumers that we need? In the meantime, a plan B ought to be, how can we mitigate a different usage for this building since we're committed to a lease at least 3.5 years in existence, and I'd like a definition of where we exist on the Garfield lease, and we're doing none of that. These numbers will continue to hurt us if we don't move in that direction. An annex, a different use for the building that will recover the bleeding situation if we can move it at the least amount of expense to where the Medicaid population might more effectively access it. I'm disappointed. All you're telling me is what we know, and you're telling me again about maybes, and the maybes are killing us. Maybe if we increase the psychiatric help with the hospital, it'll reduce costs. The intent of UBHC was to reduce costs on consumer services because the UBHC situation provided services at a contained cost, and we wouldn't continue to spin off dollars for other services. It's not happening. And there is no suggestion for an annex. If you want to save the program, you've got to move it where the consumers are. If that doesn't work, then you need to abandon the program. But I think if you can get it into that neighborhood in an annex situation with the least amount of cost, I'm not suggesting you find a building and start another lease. I'm saying, do we have a facility where we can get into at the least amount and reestablish an annex operation that might save Garfield? Because then what you would do is gradually shift UBHC to the annex location and expand it, and for the rest of the lease, utilize the Garfield location for other services that we might need the space for. Now, that's my situation, because all that this proves, a year from now, the negative situation is going to be tremendously worse, and I'm not comfortable with that. So, that's what I have to say. I was disappointed weeks ago. I'm utterly disappointed tonight because I think we've just lost additional ground with no movement toward where we need to be with UBHC, which again I say, an excellent program, perhaps in the wrong location, and we've done nothing to adjust the location. We actually re-solidified
Right.
the worst thing that we could possibly do
I think
instead of moving it. So
You raised some very good points. I think some of the data that we have to look at is, you know, regarding geographic areas that there seems to be a need. So, point well taken. I have Joan, and then Jim. Did you want to clarify something that was said already, or do you have something new? To
Yeah,
add?
I just clarification with regard to a couple of loose points, and I appreciate where you're coming from. I certainly recognize where you're at. In terms of location, one of the things we need to recall is back when we implemented the UBHC originally, we had it operating on a temporary basis out of First North. And that was a conscious decision to locate it in that area because it was closest to our main hospital provider, Henry Ford. And when we looked for a permanent location, the intent was to keep it in close proximity to Henry Ford. So that was a conscious decision to make. Now, in hindsight, would it have been better located in the southeast quadrant? Maybe, but we wouldn't have had the proximity to our major hospital provider. The other comment I wanted to make, and we'll need to do a little analysis on this, in terms of the out costs for the lease. If we get out of that lease earlier than a certain trigger point, I don't know the exact date, we're responsible for the build-out costs related to that building. And so we want to make sure, obviously, that we don't incur that cost if we do look to exit that program. We want to make sure we're at least beyond where we have repaid the build-out costs, so we don't end up in a situation where we're paying lump sum dollars back for the build-out.
Jim, I understand that, and I
Wait,
appreciate the
excuse-
negatives
Lou?
that are attached to
Lou,
it.
excuse me.
Can I not respond to that?
Correct. You cannot respond to that. Can you just wait? Let Jim
Why?
finish.
He just raised the
He is on the speaker. I'm letting him speak. You can put your name back on if you want to speak again.
That's nonsense.
And just one final point. The building issue is bigger than just the UBHC. We have crisis stabilization and the ACT program in there as well. So there are other programs that are located there that are using that facility. So when we think about that building, we have to think about if we did close it down, we'd be looking at relocating ACT programs as well as crisis stabilization programs. We could probably assimilate most of that into other locations, but it is more than just the UBHC in that building. That's it.
All right. Thank you. Next, I have Joan.
Well, I usually don't agree with Lou, but I have to now. Because I've been saying location, location, location. And since when did we have a major hospital provider? Have we always had favored one hospital? Huh. I thought any hospital. Why do we need this contract? I'll talk to John about that. But then I heard you say, Director, that you're going to the general fund all the time, general fund. I thought our general fund was pretty well down to nothing. So, I mean, I say, what's with 15 Mile? Is it someplace on 15 Mile, our facility, that you can't do something there to help this situation? Like Lou said, have an annex.
Joan, that's a good thought to bring up, but I think we need to look at the data
Okay.
and continue looking at places, you know, if that,
Well, we should do something because it's not working out here.
all right. I'm at the end of my speakers. Did you want to do a follow-up?
No, we here at the board, we understand, we're in agreement, the general fund is not gonna last much longer. We do know it's a drain on the program, maybe being idealistic in what we wanted it to work and realistic. Maybe being idealistic on what we wanted to have happen there with all good intent, and certainly understand the board's voice that maybe our best position is to not only provide data, but also, you know, to go back into committee and look at an alternative site that's going to be able to draw in the Medicaid population, perhaps in a facility that we already occupy that wouldn't be any additional cost. I hear you saying that. So we will go back and have those discussions and report back out to the board here soon.
Thank you. Do you have anything else on the management report? Just, all right, just a minute. Is there anything else on the management report?
The other item that we were going to talk about, Jim was going to talk about, was the spend down. So if you wanted to talk about that tonight or defer that till July.
Okay. Just a minute. I wanted to know if there was anything else regarding that. What else? I don't see your name on here, but go ahead.
I was attempting, Jim, to respond to some of the comments that you made. In my commentary, I never suggested closing down the operation as it exists. What I said was perhaps repurposing the remainder of the lease for other services. If we considered an annex where we might begin to grow the UBHC program and shift it into that situation closer to the Medicaid population. That would be a plan B. What I did say is if we don't do something, our GF is going to be zero, and we're going to be in bigger trouble than we are presently. And what I suggested was a personal frustration where several weeks ago we had an opportunity to do something about this, and we passed and kicked the can down the road with administration saying we did not need to do anything.
All right, seeing there's
disappointed
no
me.
new information, I'm going to move on. Let's go on to
Of
your
course
last
we
item.
will.
Thank you. John, I'll be brief. You mentioned a couple things and alternatives that you would bring forward to the board. I really would like you to include some metrics and measurements of if we don't achieve this by this date, we're going to have an exit strategy. I really want you to include an exit strategy, some markers benchmarks that you need to hit, and if we don't hit them, I want a timeline associated with getting out, and if possible, I would like that information brought to a program and budget meeting within a couple months, right? I'm thinking we should be able to pull this together by maybe September and get it on a board meeting, a board agenda by then. I don't want to wait until December or whatever to be evaluating this. I kind of want to keep it fresh in our minds if we could, please.
Okay, understood.
Thank you.
The other item that the board wanted to hear is relative to spend down. I'm gonna have Jim give you maybe real briefly, Jim, so they can take home and study the question and answer that you did on spend down. There's a few moving parts, and I'll let Jim describe them as well too. He's been corresponding with the department, and I'll just defer back to Jim.
Okay, thank you, John. This document that is going around is something that we put together for the community forum that we had in June, on June 2nd. Unfortunately, we didn't get a huge turnout there, so a lot of people didn't get this information. But really, the document here is in response to things that we were hearing from the community, things that we were hearing in the hearing of the public at the meetings here. with regard to confusion around spend down. And actually, I have extra copies if folks would like to take a copy, and we have this in our foyer at the office, and really it's a document intended for families and consumers to answer basic questions about spend down. The first box that you see there is very important because the numerous rules and variables related to Medicaid spend down is a very complicated part of the DHHS program. The rules dialogue description that I got from our DHHS rep when I was working with her to put this together is about 1.5 inches thick. There are tons of rules and variables and if, whens, and if that's kinds of things that go along with Medicaid eligibility and with spend downs. So what we tried to do with this document is to point people in the right direction to get additional information and to answer some very basic questions around spend down in terms of, what is a spend down? How do I end up on a spend down? And that really is based on the consumer's Medicaid eligibility except for income. They meet all the criteria for Medicaid except for their income. A spend down can be assigned in order to provide them with eligibility once they meet that deductible. And spend down and deductible for Medicaid are interchangeable terms. Okay. What does it mean to have a deductible? The deductible amount is calculated by looking at the second page here. And this is a DHHS document. It's got a couple of acronyms on here that I apologize for. But when you look at the example, the 1248 RSDI, that's really the gross income. And when you take the gross income, the dollars that can be excluded, the dollars that are protected income for a single individual, what's left over is what that spend down is going to be for a consumer. So in this case, $1,248 minus $428 in exclusions protected income, you're looking at a spend down of $820. And this is right from DHHS. They provided this as kind of a worksheet so that people can understand how that's calculated. Because a lot of people will say, my spend down is $800, $1,200. How do they get to that? And so this will help people understand what that means. You are not considered to be covered by Medicaid, meaning we can't pay for services until the monthly Medicaid deductible is met. We've heard that, in meetings here. We hear it on a daily basis from consumers in hearings and from program folks who are struggling with consumers that have a spend down and can't receive services until they meet that spend down. How does a Medicaid deductible affect my mental health services? Because we don't have the general fund dollars to support the spend down amount, to pay for that spend down amount prior to someone meeting the deductible, we can't provide services until that happens. So the deductible must be met, and then very importantly, it needs to be communicated to MDHHS before that spend down can be lifted and that deductible is officially met, and we can initiate services then. Who establishes the deductible amount, and can I appeal the determination? DHHS is the sole authority in terms of the determination of what that spend down amount is. There is an appeal process for that. The consumer would need to go through their MDHHS caseworker in order to get information on that. And one of the things that I included here is on about the third page in, there's a benefits summary. And in the upper right-hand corner, it's blocked out on these because this was taken from a consumer case. That contains information related to the DHHS office that their claim is being managed through, and their specialist ID and phone number. That is absolutely the best place that a consumer can go to get information regarding, how their deductible is calculated, do they believe it's correct or not, and to initiate an appeal for that spend down amount. So that's very important information for folks, is to have that specialist ID and phone number so that they can contact DHHS. How do I or my family member meet the deductible amount? Whenever a Medicaid expense is incurred, it needs to be reported to DHHS once the deductible is satisfied and DHHS has documentation of that, that deductible is met, then they're able to turn on the coverage, which allows them to access our services. We have the DHHS liaison in our office, and so what we're suggesting through this last paragraph is that the information needs to go to Lansing, but to also send it to Danielle at our office, because she can process that information directly, and usually within 24 hours, turn flip that spend down flag where they're not covered to covered. And so people can initiate services much quicker, okay? I put a copy of the DHHS deductible report form in here so folks can be familiar with that and where it needs to go. Fax number is on the report. And it really, you need to capture any medical expense and provide documentation of that expense for DHHS to process, and then the spend down and deductible is met. Then finally, if someone has received a notice of denial, termination, or reduction of services from MCMH for whatever reason, there is an appeal process, and that is our standard local dispute resolution appeal, and contact our ombudsman for that information. Okay, so in a nutshell, that's information related to spend down. Our DHHS liaison did offer to come to a meeting, and I think ideally one of our morning meetings, it would work out great to answer any questions that may come up regarding spend down.
All right, thank you. One of the things we heard here under public comments was someone who was denied services because they had the spend down. This answers some of the questions that we had, but do you know, can somebody private pay something, and that the first, whatever their spend down is,
right?
So they can receive their services, like it was Clubhouse, I think was the
Mhm.
example that I remember hearing.
Yeah, and that's an excellent question, and we have had some discussion about that, I think here, as well as a lot of multiple discussions within administration regarding this. We have sent a request up to Tom Renwick at DHHS to weigh in on the legality and feasibility of having someone private pay, have a private pay arrangement with a provider to provide services. Because as we got further into it, there's some pitfalls that potentially can come up. In a private pay arrangement, the provider would not be bound by a person-centered plan. They would not likely have recipient rights protections. There's a number of things that we feel like, without having the department's blessing on this, we might be getting ourselves in trouble if we try to move forward. So we have a request into Renwick. He did respond to it and say he was passing it on to legal and to rights, and he'd get back to us as soon as he can with a response.
Right, because I would think we would want the consumers to stay under the umbrella of the recipient rights.
Right.
And, okay, all right, thank you. So
Mhm.
we're waiting to hear more.
Yes, correct.
From him on that. And I would say if there's probably more questions that haven't been answered. I don't know if we can answer them tonight, but let's see. Joan, your name is still on here. Is that from before? Yeah. Okay. Linda, and then Lou.
One concern we had was this term, ability to pay. It's a calculation
Yes.
that was holding up people from services. Is that explained in here? That there was supposed to be some sort of clarification on the spend down and the ability to pay.
That is not addressed in here. This is strictly information from DHHS with regard to how the spend down operates. Typically, if somebody has an ability to pay, it is around their spend down amount. So if they're satisfying their ability to pay, it's close to spend down. Not always. Some is, ability to pay is higher, some is lower. So that obviously is a factor when somebody has spend down, but meeting your ability to pay doesn't always meet your spend down.
Right, and it was a holdup for people wanting to go get certain services
Mhm.
from us. I forget the details of the discussion, but some way to have that waived, or that other counties didn't use it, or does anybody remember that meeting with the ATP discussion?
ATP is taxable income base, and once that's derived, all of our consumers have an ATP. And whatever that is the amount that the consumer has to pay. And the caveat, I'm sorry, the ATP ability to pay is based on taxable income. And there's two different forms you use, one non-residential, one residential. It's done annually. Caseworker goes through the finances with the consumer, establishes ATP, and that's the amount that the consumer may pay. And the caveat or the double-edged sword here, whatever, is that the consumers, our policies indicate that the consumer is required to pay the ATP or the deductible, whichever is the lesser amount. But all of our consumers have an ATP in the file.
Lou?
Actually, this spend-down situation on a monthly basis is the most difficult challenge for the consumer that I can imagine. And recording the spend-down situation on a monthly basis, subject to approval, is extremely difficult to comply with. It must have been 3 years ago that John and I attended a PIHP meeting in which Tom Renwick was there supporting the State Department at the PIHP meeting. I brought up the spend-down situation as a continuing crisis for consumers. If you were to plot their monthly ability to access Medicaid services based on their ability to monthly comply with the spend-down, you would end up with a graph technically that would be peaks and valleys when they could comply and where they couldn't comply, where they would receive Medicaid services, where they could not be eligible to receive Medicaid services. It's almost ridiculous. I suggested that the State Department might consider an annual program in which the spend down could be adjusted as yay or nay, in which a consumer could provide the ability for spend down on an annual basis and be approved for 12 months. I suggested that the formula might be led by the State Department to adjust the formula and how the spend down was arrived at to be more friendly consumer, etc. basis. The PIHP directors who were there, as I recall, and John, I'm subject to your memory here, agreed 100% that the program needed to be revised, that the spend down situation as it existed was difficult, too complex, hard to handle, and placed the consumer in a continual negative position, almost to the point of, quote unquote, it being cruel. This month I'm eligible, next month I'm not eligible, based on whether or not I could match the spend down formula and have it accepted. Tom Renwick responded by setting up a committee 3 years ago, maybe 3.5 years ago, to analyze the spend down situation and report back with a situation that might handle the monthly difficulties that our consumers are experiencing with attempting to productively and positively meet with the spend down situation. Perhaps, John, an inquiry might be made of Tom and ask where the hell that 3-year or 3.5-year committee is, with a report that might alleviate the spend down situation for our consumers in a positive way. We've heard nothing. I don't even know if the committee meets. I don't even know if it's still in existence. I don't even know where it is. But I think somebody ought to ask him.
You're spot on with that. I recall those conversations too. You know, the reason the Crossroads Clubhouse not the Crossroads, but all the clubhouse block grants are there, was the question. I asked the question of the department a few months ago, 6 months ago, 4 months ago, whatever. I said, what happened to the spend down subcommittee group that was occurring out of Medical Services Administration? And if you look at page 132 in your packet tonight for the clubhouse program, the sustainability plan, the thing that we put in there is, I'll read it to you. CMH again recommends that the Michigan Department of Health and Human Services continues to monitor the activities of Medical Service Administration, MSA, and more pointedly, the spend down work group that was formed in 2014. The challenges and perceptual unfairnesses of the Medicaid spend down in Michigan is well known throughout the state, and it was the MSA spend down work group who accepted the task of addressing the shortcomings of Medicaid spend down and the negative impact of the services delivery to vulnerable people. Hence, Macomb CMH is optimistic that as this block grant expires on September 30th, 2019, that the MSA spend down work group will then have some formidable recommendations that will address the issues herein and those attending clubhouse programs. So we have begged the question. I will do it again, and we put it in our sustainability plan. So as they read this, it's back on them. I get it. You know, they got to do something about it.
Thank you. Does that conclude the management report? Thank you. All right, are there any other agenda items? Seeing none, we'll go to item number 12, hearing of the public. Is there anyone from the public that would like to address this body? You have 5 minutes. Please give us your name and address.
Good evening, I'm Sean McGregor. I live down on St. Clair Avenue in Macomb County. Just on a light note to end the evening, I'm with CEO, and I just want to thank you guys again for the 11% rate reduction being restored. And basically, I'm here just to give you a report on what we're doing with the company and how we're going with everything. And first thing I have is with CEO, through our art center, we've been creating what we call dirty pour art vases. They've been selling these through a micro business for about $5 a piece. So I'm just going to pass around if you guys are interested in looking at it. And these were completely made by the individuals, by the way. Also, CEO at our Clinton Township location hosted their 4th annual parking lot talent show. It went very well. There was about over 70 people in attendance. As well, at the Clinton Township location, we are hosting Guardian Angels. It's for the parents and advocacies. The meeting's on June 28th, and the meeting will focus on the home and community-based services. More community center updates. Angerville has planted and raised their garden beds, and we've been constructing those. Mount Clemens also participated in Relay to Life on May 19th and raised over $2,000 for cancer. The event raised a total of $88,000. At our Washington location, they've also planted their garden and have been delivering more Meals on Wheels throughout the week. And they've also gained 9 individuals as well. At CEO, we are hosting our 24th annual summer picnic on August 23rd at Metro Park. The HCBS audit was completed at CEO Clinton Township with no recommendations. And just again, thank you for the restoration of the 11%. And I have cards from all of the Macomb County locations signed by all the employees thanking you guys. So thank you again.
Thank you very much. Is there anyone else that would like to address this body?
Hi, I'm Joe Mack. I have a number of homes under lease with MCCMH since 1995. Recently, my wife of 29 years, Debbie, was diagnosed with rectum cancer. For the last 18 months, she was misdiagnosed and it continued to grow. With the cancer. I'm not? Okay. Recently, my wife of 29 years, Debbie, was diagnosed with rectum cancer. For the last 18 months, she was misdiagnosed and it continued to grow. With the cancer's continued progression, during an exam at a specialist, an abnormal growth was discovered in early April, and it was ultimately diagnosed as rectum cancer. And she had an operation at U of M on May 21st. There's not one thing through this entire ordeal that I have done that I would change. From being at her side at every doctor's appointment, MRI, CAT scan, second opinion, cancer board meetings, as well as driving a round trip daily for 7 days while she was hospitalized in Ann Arbor. I assisted in daily injections, helping her in and out of her recliner. One of the things that I realized through this entire ordeal was how much I loved her and how much I needed her and how much this has affected me. I'm openly coming out this evening and unveiling a condition that I have called depression. My wife's medical condition sent me into a deep depression. I gained over 20 pounds from April through June, and at one point prior to her surgery, she was more concerned about me than her own situation. That's 29 years of all the ups and downs called marriage. When her diagnosis was confirmed in early May, I informed MCCMH staff about her medical situation and asked for help if a home emergency were to arise. I want to openly apologize to Tracy how rude I was during a phone call. It was late April, early May, and at that time we did not have a firm diagnosis or discussed how we were going to publicly handle this. I was truly stressed at one of the darkest points in my life. Again, Tracy, I'm sorry. At this time, through this time, all emergency situations such as failed sump pumps, no AC on a Friday, the weekend before Memorial Weekend when it was going to be 90 degrees, a dead possum and a dead cat outside a house the same weekend before Memorial Day, and a roof was replaced. There are items that I had committed at lease renewal with a time frame of spring of 2018. With the weather that we had in April, which I consider the second March, my wife's cancer and my depression, I was unable to meet a number of those timelines. None of those items that I have committed to were putting a home's license in jeopardy. Reaching out to MCCMH, I asked for help again wherever I could get it. Again, I reminded staff of my family emergency and all emergency situations were being addressed, as well as where my priorities were. I hope everyone in this room would do the same thing that I did if they have a family member that had this come up. During subsequent emails with MCCMH, I understood that our relationship had been strained, and I want to do everything that I can to rebuild a once strong partnership. I hope to continue this relationship, but I felt it was time to disclose my medical condition as well as my wife's to all parties involved. Hopefully you as the MCCMH board will want to continue this working relationship. Thanks for your understanding and kind words to those that have reached out during this time and one of the most challenging times that my family's gone through. Thanks.
Thank you for sharing that, Joe. Is there anyone else that would like to address this board? Anyone else? Hearing none, I declare this meeting adjourned.